Our presenter today is Daniel P. O'Connor, PhD, ATC. Dan is an assistant professor in the Department of Health and Human Performance at the University of Houston. His research interests focus on evaluation of the effectiveness of health-related interventions and the use of statistical models to explain individual variation in outcomes and health-related quality of life. He has authored and co-authored more than 60 papers in peer-reviewed medical journals and a number of book chapters, as well as the textbook Clinical Pathology for Athletic Trainers, currently in its second edition. And now, Dan, I'll let you take it from here.
Okay, thank you, Lindsay. Hopefully everybody can hear me just fine. First, before we get started, I'd like to acknowledge my collaborator on this project, who's my doctoral student, Mr. Mark Knobloch, the Joe W. King Orthopedic Institute, who provided some funding during this period, the NATA, and especially Lindsay for inviting me to prepare this presentation. And I want to give a quick shout out to University of Central Oklahoma class, Kanice 5623. I think you're sitting in on this morning. Welcome, Broncos. Okay. The issue of including ECG as a routine part of the pre-participation exam has been controversial for at least 20 years. This presentation is going to focus on answering, I guess, or addressing why this isn't really a simple question and why there's no simple answer. So sudden cardiac death is the #1 cause of death during athletic participation. And we've all seen headlines. These are a few just from the past 12 months. We've seen these stories. We've heard some that are encouraging, actually, when medical staff discovered a cardiac problem, or when a quick-acting athletic trainer who has the proper resources on hand actually saves a life. And I suspect many of us in this webinar today have experienced the situation first or second hand. Either ourselves or someone we know has worked with an athlete who's had a major heart condition, or we've responded to sudden cardiac event on the field or gym. And close to home to me, these bottom two headlines, Magnolia is only about 50 miles from where I live. The player collapsed, was resuscitated, and has since recovered after hospitalization. And similarly, this Pearland event is only about 2 miles from where I live, and the AT that responded in that particular event is a very close friend of mine. Both these events, which happened well within 50 miles of my house, happened within a 12-hour period. And I put this up to make the point that sudden cardiac death is a very serious problem, obviously, and while it's very rare, as we'll see, it's unfortunately not nearly as rare as we would like. So the controversy about ECG and pre-participation exams stirs some passionate responses in many people, including myself. Most people have fairly strong feelings about this. So I'm going to provide a disclaimer at this point. I'm not going to argue for or against using ECG in an absolute sense. And I'm not going to say ECG screening is a bad idea or that it's easy to implement. There's a lot of gray area. This issue is obviously not black and white, which is part of what makes it controversial. What I do hope to do is provide some information that you'll be able to use in deciding whether including ECG as a routine part of your pre-participation physical process is a feasible and useful option for you in your setting. I should say also at this point I'm discussing resting ECG, which is the most common type used in pre-participation exam. Exercise or stress ECG is a different test entirely, and to my knowledge, no one's recommending that for routine use. So everywhere I say ECG in this presentation, I'm talking about a resting ECG. Okay, so what am I going to discuss? I'm going to review the epidemiology of sudden cardiac death for two reasons. First, to provide the scope of the problem, which is sometimes misunderstood. And secondly, the epidemiology of sudden cardiac death affects the accuracy of ECG, which is a central issue. The accuracy of ECG is a central issue in this whole debate. And we'll see why the epidemiology affects that as we go through. I'm going to review the accuracy of ECG in athletes by providing an overview of diagnostic testing in general and some numeric examples, some of this information from the Journal of Athletic Training article in the June issue that Mark and I wrote, reviewing some cost issues. Next, I'll talk about the role of electrocardiograph in pre-participation exams, advantages, disadvantages, and I'll finish up with just a few things to consider if you're going to decide whether ECG is part of your pre-participation process or not, some things that you probably should consider to ensure success of the program. So let's start by taking a look at the scope of sudden cardiac death in the United States in young athletes. So this list shows the rates of death per 100,000 persons per year for adolescents and young adults. This represents about, this list, 85% of all causes of death in this age group. This age group, 15 to 24 years old, is typically in the United States anyway, what we're talking about in the sudden cardiac death ECG issue. So all told, about 75% of all deaths in this age group are considered preventable. For example, motor vehicle accidents or not wearing a helmet while biking are certainly thought of as preventable in many cases. And just to be clear, these are rates in the general population. This isn't just athletes. So as we can see, there are many other causes of death that are more common than cardiac disease and sudden cardiac death. So what I want to make 2 points from this list. First, that sudden cardiac disease as a cause of death has a much higher rate than sudden cardiac death. Many cardiac diseases are chronic and debilitating and probably wouldn't appear in athletes, particularly competitive athletes, because performance would be so severely limited. So, for example, anything leading to chronic heart failure would probably prevent athletic participation, and so we wouldn't really see that in athletes. It wouldn't be a concern for screening. What we're concerned with are the sudden cardiac death causes as a subset of cardiac disease. So anything causing ischemia to the heart muscle or an arrhythmia, for example, would be really what we're focused on in athletics. And I want to point that out because sometimes these things are confused, even in the medical literature, when we talk about screening for cardiac death, is that when we say how prevalent is cardiac death, how common is it, some people are reporting cardiac disease rather than sudden cardiac death. And as you can see, that those aren't the same thing. So the second thing is, from a public health perspective, the country and our society has limited resources to apply to many, many problems. And so you can see from this list that some of these other more common causes of deaths would, if we address those problems, would actually lead to saving many more lives. However, I don't think that that means prevention of sudden cardiac death in athletics is unimportant or shouldn't be invested in, because it is the leading cause of death in athletics. So I just want to say, from a societal point of view, there are many other causes of death that are more common in this age group. And when resources are limited, legislators and other policy and decision makers take this information into consideration. So we'll talk later about, just very briefly mention that, maybe going to legislators and trying to get programs implemented across states or countries, even within counties, is very difficult, because this is the type of thing, if we're going to put our limited healthcare dollars into something, this is way, way down on the list, because just for the plain fact that it's relatively rare. But again, I think it's important. So rare doesn't mean unimportant. So this is a graphic that just shows the scope of the problem. In 2008, there were about 7.5 million public high school athletes in the United States. This is from the National Federation of High Schools Association. So while estimates vary, their thinking is that approximately 1 in every 333 athletes would be expected to have some sort of cardiac abnormality. So across the entire United States public high school population, that would be about 22,000 athletes. But as we've just seen, so the green line, little sliver here, turns into this entire circle here. And then what we've seen in the previous slide is sudden cardiac death is actually a much smaller part of that green circle, that's little red sliver, which wouldn't even show up on the big blue circle to the left that represents all athletes. And the rate that we have here is about 1 in 160,000 athletes a year, or about 50 cases of sudden cardiac death a year would be expected on average across several years. Some researchers argue that the rate is probably only half of that, but this is sort of a worst case scenario, so we'll use these numbers moving forward. But I guess for what you can see from this graph is all athletes participating in high school sports, very, very few are actually at risk for sudden cardiac death, but there's a fairly large number that have cardiac abnormalities. Okay, so what does all this mean in terms of ECG and the pre-participation exam? If you do all the number crunching, it's only about 1 in every 450 athletes who actually have an ECG detectable cardiac condition are at risk for sudden cardiac death in the following year. And I think the analogy I'm going to want you to come away from this is that when you do this type of screening, you're looking for the needle in hundreds of haystacks, not just one haystack. And actually what ECG does is detect the haystacks, and then somewhere in there there's the needle that's going to be a sudden cardiac death risk, but it's determining who that risk is really going to be the problem. So even if ECG was a perfect test, which it's not, in detecting perfectly accurate in detecting cardiac abnormalities, we'd still have difficulty saying this particular person is at increased or at high risk for sudden cardiac death. So this leads us to our first challenge, and we'll have 5 of these challenges that we'll summarize at the end and talk about just briefly, well, how can we maybe address some of these? But it's that ECG doesn't predict risk of sudden cardiac death. There are a lot of athletes that if you do ECG screening, you'll detect cardiac abnormalities, but very few of those athletes are at risk for a fatal event. Now, they are at higher risk than the general population, and there's some value in doing that. But a lot of ECG screening programs are promoting that they're preventing sudden cardiac death, and I'm not sure that they can say that. What they're doing is finding people who are at higher risk than the average public, but not necessarily at extremely high risk. Okay, so looking at what causes sudden cardiac death in the United States, continuing our epidemiology review. This list is the 5 most common causes of sudden cardiac death. This is about 2/3 of the cases, or 67% of the conditions that cause sudden cardiac death in the United States. It's well established in the United States that hypertrophic cardiomyopathy is the leading cause of sudden cardiac death. And there are several actual pre-participation screening programs that are targeted toward identifying that condition in particular, not so much these other conditions. But the reason is because it's a third of all sudden cardiac deaths are related to HCM. So the most concerning thing about these conditions relative to PPE, excuse me, and sort of what drives this, one of the drivers for this controversy is that most of these conditions actually can be in fairly advanced stages without having any symptoms, producing any symptoms. So the symptoms of cardiac conditions are classically lightheadedness during exercise, shortness of breath, syncope, chest pain, and so on. Well, these can be fairly advanced before those symptoms start to show up, and that's what's really concerning. It makes detection by routine medical history very difficult. And it's often, in fact, said that the first symptom of many of these conditions is, in fact, sudden cardiac arrest, which is clearly unsettling. So if we can detect these conditions, we may be able to prevent some of these deaths in athletes. Unfortunately, not all these conditions are detectable by ECG. So 4 of the 5 leading causes are detectable, but the second most common cause, coronary artery anomalies, which is almost 1 in 5, 1 in 6 of the sudden cardiac death cases, is not really detectable by ECG unless there's been some damage to the heart, the myocardium, either through a sudden cardiac arrest or a myocardial infarction, and that's chances are that probably what didn't go unnoticed, and that an athlete who's had a heart attack would have that in their history. They wouldn't be asymptomatic. And there are other less common causes like some valvular deformities and so on that again are not, ECG is not going to detect those causes. So while this limits the utility of ECG, again, for targeting the prevention of sudden cardiac death, other tests may be needed, and in fact, in some cases, may be more appropriate, such as echocardiograph or other stress tests and so on, that may, in fact, for particular individuals, be more appropriate than doing an ECG if you're talking about screening. It's not, using ECG by itself is not really going to be effective for trying to screen the entire population of athletes for sudden cardiac death-related diseases, because it's going to miss a fair proportion of them. It is going to detect some, but it's going to miss others. Related to this issue is that the risk of sudden cardiac death depends on the nature of the population. So here are some things that affect your risk for sudden cardiac death if you're a young athlete. The first thing that's notable is that sudden cardiac death is predominantly a male phenomenon, that 9 of the 10 cases are males. Males are at much higher risk for some reason for sudden cardiac death than are females. But there are a lot of other factors. Ethnicity plays into it, that 2/3 of hypertrophic cardiomyopathy related sudden cardiac death occurs in African American males. So they're at much higher, African American ethnicity is a much higher risk for sudden cardiac death due to a particular condition than other ethnicities. Um, Age is a factor. Older athletes, once you get to 30, 35, over 40, you start to run into atherosclerosis and other typical cardiac conditions we see in the general public. And they're certainly at higher risk for sudden cardiac death, but there are some that uh, are some arrhythmias and so on that actually are the younger you are, the higher risk you are. And again, we wouldn't necessarily see that in a teenage population because they probably have been detected either through an event or through medical screening at a younger age. But the point is that age can be related to these things. Body size, typically what we think is the larger body size football and basketball players are at higher risk for certain conditions, especially, again, hypertrophic cardiomyopathy. But it turns out that there's some evidence that smaller body size is related to some types of arrhythmias, and in fact, in older athletes, related to atherosclerotic problems for the simple reason in atherosclerosis that their vessels are smaller in diameter. Family history is important. That's why I know in Texas we have a standard history form that's used in the PPE. But it turns out that 10 to 20% of all sudden cardiac death cases have at least one other sudden cardiac death close case in a close relative, an immediate relative. So it's one of those extremely important things to ask. If someone's had a history of that in their family, they're at considerably higher risk and probably need additional screening. Activity of or intensity of activity, football and basketball, as I've already mentioned, and are at higher risk for sudden cardiac death. And the thinking is that the intensity of the activity puts strain on the heart, and that may lead to the event. And then there are a number of other things in the environment: heat, cold. There appears to be some evidence that there are regional or geographic differences, sociocultural effects, diet, and so on. Access or experience with drugs. There's a whole multitude of things that feed into the environmental aspect of this. So it's not a straightforward problem. Is that this whole issue presents very differently depending on what the actual athlete looks like. So that's our second challenge: is that the risk of these abnormalities in sudden cardiac death vary widely in these populations, and that affects the accuracy of ECG, as we're going to talk about next. And it sort of raises the question: should we screen everyone, or should we attempt to target particular groups and do what's known as risk stratification, and then conduct screening tests appropriate to whatever the risks are? And again, I already gave the example. Some may be better served by getting an echocardiogram rather than an ECG. But the only way you would know that is by stratifying and saying this person's at higher risk for a certain condition than another. So I've discussed so far the epidemiology and how it's related to ECG accuracy, but let's talk for a minute about the nature of diagnostic testing in general, and what that tells us about what we might expect from screening using ECG in athletic populations. So there are several sources of error when you use ECG in this setting. The first thing is we're talking about young people, and a child's heart isn't an adult's heart. The ECG pattern in children is much more variable from child to child than from adult to adult. That makes interpretation difficult. Things that would be clearly abnormal on a adult ECG aren't necessarily out of the ordinary on a child's ECG. An athlete's heart may not be normal, and everyone's heard the so-called athlete's heart condition, where you have thickening of the heart muscle and so on as an adaptive mechanism to chronic exercise. And then within that, even within athletes, elite athletes' hearts are much different than just your typical competitive athlete. So somebody like Lance Armstrong, for example, his heart and his ECG are going to look a lot different and still be considered healthy compared to the normal person, certainly, and even to some athletes. But again, that just confounds the whole issue of interpreting ECG. ECG is historical and not predictive, and this is something that I got to thinking after going through my own annual physical and got an ECG, and the doctor was explaining to me that, and it makes sense, that this only tells me what's happened with your heart, or maybe what's happening right as you're sitting here. It doesn't tell me what's going to happen to your heart tomorrow. You could have a heart attack tomorrow, and so on and so on. So I think that's a good thing to keep in mind, is that it can't predict the future. All it tells me is what's already happened to the heart. It gives me a record, and perhaps if there's a malfunction in the heart right at that time, it will detect that. And this is important in things like arrhythmias, which may not be constantly present. They may come and go. And in a resting ECG, it just may not be there at that particular time, and it would go undetected. And last thing is abnormal ECG or even abnormal cardiac structure doesn't necessarily mean you're at increased risk of sudden cardiac death. So again, I've already touched on that. It's not really helping us to predict the sudden cardiac death. It may help us to predict or identify people with cardiac abnormalities. So no test is accurate, and it's problematic in high-stakes tests. You can change the criteria of what makes a positive ECG or a negative ECG. But the sort of trick in testing is, okay, if I set the criteria very, very stringently, what I'm going to end up doing is missing people who have cardiac conditions because I've set my criteria too high. So let's go conservative and set it a little bit more permissive, and we'll have more positive tests, and we'll catch more of the people who have the disease. But then we have the other problem where we're, in fact, including many, many people who are healthy and saying they have a positive test. And we'll see here in a minute that's actually the problem in ECG. And I thought I would give an example of how this accuracy issue has played out in another arena, and that's in random drug testing. Here in Texas, we have a law requiring random drug testing of all high school athletes for anabolic steroids. So in the first year of the program, they tested about 45,000 athletes, and they had 19 positive test results. So if the test was perfectly accurate, which we already know it's not, what that's telling us is that the prevalence of steroid use in high school athletes in Texas is about 1 in 2,400 athletes, which is pretty low. A lot of schools don't have 2,400 athletes. A lot of districts don't have 2,400 athletes. And this law, part of the reason for passing the law, which I think it cost in the neighborhood of $8 or $9 million that first year to implement it, was that steroid abuse was widespread in the high school athlete population. Well, 1 in 2,400 isn't necessarily widespread. So that's the first sort of issue. But we, on the other hand, know the test isn't perfect. So what if we just guess and say that the rate of actual steroid use in reality is 1 in 1,000 athletes, so a little bit more than twice as prevalent as what was detected? If that's the case, then the testing actually missed 59% of users, and if the rate was 1 in 100, it missed 96% of the users. So again, this is an issue of test accuracy. Is what I suspect is they set very, very stringent criteria because the last thing they want to do is label someone as a steroid user when in fact they're not. The price you pay for that is you're probably going to miss some. Now, I'm not making a judgment about this Texas program or random drug testing. The state of Texas actually considers it a success because they interpreted the very low positive rate as that the testing program itself is serving as a deterrent to steroid use, which is certainly possible. But I am using this as an example that the inaccuracy in testing, which can't be avoided, really has real consequences. So we're going to say, okay, how do you determine how accurate a test is? And that's through using properties of the test known as sensitivity and specificity. And I'm sort of a biostatistics guy. That's my thing. So bear with me for just a minute. But I think it's worth talking about this so that when we talk about ECG specifically, it'll make more sense. So here's 100 patients, a test that we have, just some generic tests that we're testing for a disease in 100 different patients. And what this will tell us is that this table is laid out is that 25% of the people have the disease. So under the column labeled yes by disease, we have 25 people who have the disease out of 100. So the prevalence is 25%. So if I talk about sensitivity, I'm going to start talking in this column. And what I want to know in sensitivity is, can this test detect people who have the disease? So people with the disease should have a positive test. And what we see is that, in fact, there were only 20 of the 25 people with the disease had the test. And so that's what we call sensitivity. 20 of 25 or 80%. This test has 80% sensitivity. If you give this test, it will detect 80% of the people who have the disease. So the counter side of that is specificity, which is people that don't have the disease should have a negative test. And so it's the same type of reasoning. We look and see that 69 people who are free of disease, who are healthy, had a negative test, and that's what we'll call the specificity. This test has a 92% specificity. It will give a negative test to 92% of the people who don't have the disease. So when we look at that's looking at the columns. But of course, we don't know who has the disease and who doesn't have the disease. That's why we're doing the test. So what we have to deal with more often in the realistic situation is the rows. We know how many people had a positive test, and we know how many people had a negative test. What we don't know is who does and doesn't have the disease. So this gets into the predictive values of testing. And we have positive and negative predictive values, and I'm not going to get into it, but instead of looking at the columns, we're now looking at the rows. So here's 26 people that have a positive test, and we see that 6 of them are what we call false positives. They have a positive test, but they actually don't have the disease. And so a predictive value will say, if I have a positive test, what is the probability or what percentage of people with a positive test actually have the disease? And we see that 20 people out of 26, this number, or 77% have the disease. So the positive predictive value is 77%. And by following similar logic, you can see that of the 74 people that have a negative test, 5 of them actually have the disease. That's called a false negative. The test is negative, but the disease is present, and you get something called the negative predictive value, which in this example is 93%. So, okay, that's all fine and good. What does that mean in terms of ECG? Well, ECG, the test depends on a couple of things. The sensitivity and specificity we've already talked about because you want to try to detect or exclude people, but it also depends greatly on the prevalence of the disease. And so what we're interested in is that if you have a higher prevalence of disease, if it's very common, then it's going to improve the predictive value of the test. More people that have a positive test are going to have the disease. But we run into the opposite problem in cardiac testing and ECG in particular in young athletes is that very, very few of them actually have the disease, and then even fewer of them are at risk for sudden cardiac death, and that actually decreases the predictive value. And again, another sort of silly example, but if you take a urine pregnancy test, which is extremely accurate, much more accurate than either the steroid test or the ECG, but you take this urine pregnancy test and you give it to men instead of to women, and you give it to enough men, you're going to get a few positive results. Now, obviously, the predictive value of a pregnancy test in women and men is 0 by definition, at least for pregnancy. But the point is that you're going to, just the nature of testing, no matter how accurate, because it's not perfect, is always going to get some false positives if the condition itself is very, very rare or even non-existent. So in terms of cardiac problems, this is some numbers that I used in my Journal of Athletic Training paper, and we abstracted these from existing literature in 2008. And this is just a hypothetical example of 10,000 high school athletes. And what we can see from this is that the false positive rate is really, really high. Almost all of the positive tests, 16% of the people had a positive test, almost all of them, over 99%, were false positives, and only 0.6% of people that had a positive test have cardiac problems. So obviously this is sort of an issue, is that here's 10,000 high school athletes. Let's say we screen them using ECG. We're going to get 1,568 out of 1,577 positives are actually healthy and have no cardiac condition. Only 0.6% have the cardiac condition. This is about 1 in 167 athletes, roughly. So 1 in 167 people with a positive ECG actually have the problem we're looking for. Much more comforting is, and I think this is what a lot of people focus on, if you have a negative test, it's virtually certain, with over 99.9% certainty, that you don't have the disease. So we're going to rule out a bunch of people who don't have the disease, which is a good thing. But I think that what I'm going to talk about is the bigger problem is, what do you do with all these false positives? Some people had some issues. Let me go back one slide. Some people had some issues with some of these numbers we used. This prevalence number, for example, is actually considerably, it's about a third of what the general population sudden cardiac abnormality rate is. We used a lower number because, as I said earlier, a lot of those cardiac conditions people aren't even going to make it into athletics because the conditions themselves are so debilitating. And that was sort of one of the assumptions of our model. It may or may not be true. They also had issues with these numbers, which again we got from the literature. We didn't just make them up out of the blue, and they're sort of upper end of what was reported in the literature at the time. And these aren't great numbers, sensitivity and specificity numbers for any kind of a test. That especially sensitivity is relatively low. You'd ideally want both of these things to be over 90%. But being the nature of the test has to be interpreted by a human and so on, it's not a perfect scenario. So what I did for this presentation is reran using some of the highest numbers I've seen reported in the literature, and these were actually reported in a study done among high school athletes in this region. So these aren't made up numbers either. And what we found in that, what they've reported in that study is the cardiac abnormality rate was actually about twice as high as the general population, which, okay, that's fine. So we'll use these as sort of best case or worst case, as the case may be, scenario. In other words, this is as accurate as I've ever seen ECG in athletes reported. That's the highest, best I've ever seen. And this is the highest prevalence rate. Well, not the highest reported, but in the United States, that's pretty high. It's twice as high as the general. So this is sort of a best case scenario. We have high accuracy and we have an increasing prevalence. So how did that affect it? We still see that there were quite a few people that had false positives, and only 6.5% of the people that had a positive test have a cardiac problem. This is about 1 in 15. So about 1 in 15 people that had a cardiac or had a positive ECG actually had a cardiac problem. So 14 of 15 didn't. And again, we can still see that if you get a negative test, that's a very good thing. Virtually no one with a negative test. There were a few, but virtually no one with a negative test would have the disease. And again, this is that same hypothetical 10,000 people. So higher accuracy, sensitivity, and specificity, and higher prevalence of the disease did improve the predictive value, but it's still not really where we wanted. Most of the positive tests are still they're in athletes that have no problem. No, they're healthy. So the false positive becomes a real hindrance to interpreting ECG. Only 1 to 6%, depending on which numbers you use. Our numbers are the best case scenario numbers. Have a positive with a positive ECG have the abnormality. And this, if we remember that only 1 in 450 people with an abnormality are at risk for sudden cardiac death, this translates to somewhere between 1 in 7,500 to 45,000 people who have a positive ECG are actually at risk for sudden cardiac death. So this again becomes a real issue when you're trying to interpret this, and leads to our third challenge, is that the ECG testing, if you do it in everyone, is going to result in a lot of false positives. And as we'll talk about, that really becomes an issue. What do you do with all those false positives, or what do you do with the positive tests? You know, the vast majority of them actually are in healthy athletes. All right, so we'll start talking at this point, after we reviewed the epidemiology and the accuracy. Okay, how does that fit into the role of ECG in pre-participation exams? And we'll talk about some guidelines, and we'll say, okay, there's some controversy here, the disagreement in these guidelines, and go through the evidence they used and try to interpret some of that. So the American Heart Association has a report. They have conferences every year, but Bethesda Conference 36 was the last time they looked at cardiac conditions in athletes, and that was in 2005. They do this every 10 years or so, so the next one will probably be 2015. But relatively recently, they recommend a 12-point screening exam. It includes some history, family history questions, personal and family history, and auscultation, cardiac auscultation in both sitting and in standing. And the reason in standing is because there's a certain murmur associated with hypertrophic cardiomyopathy that's more detectable in standing. Palpation of both femoral arteries, checking for stigmata of Marfan syndrome, and measuring blood pressure, resting blood pressure. So that's the AHA 12-point thing. They don't include ECG. They don't recommend it as a routine part of the pre-participation exam, but they certainly say don't do it. It's not prohibited. It's just that they don't recommend it, and they give a list of reasons, some of which we're going to go over. Now, on the other side of the coin, the European Society of Cardiology International Olympic Committee in 2004 and 5 came out with a set of guidelines for screening athletes. The history and physical is much more extensive than what the AHA 12-point plan is. They include, I think, 5 or 6 more questions. They have a few more physical tests, and they actually include ECG, 12-lead resting ECG, as part of the standard physical examination recommendation. So this has really led to a lot of the controversy, and I should say at this point too that the AHA guidelines are actually followed by remarkably few states and schools in the United States. That it really we can't get people to even do the 12-point screening. I'm not sure how we're going to get them to add ECG. That's perhaps another issue on a case-by-case basis. But I think the thing is we need to really get consistent on doing at least the 12-point screening program in the United States if we're going to try to consider something like the European model. But there is no real standard in the United States on pre-participation physical examinations. There's just these recommendations. So state to state it varies. But why is it that the Europeans recommend using ECG and the Americans don't? And largely it's based on this particular study that was published in the Journal of American Medical Association 2006. And this research group in Italy has done a large amount of work, and they've had many publications other than this one. But this is sort of the keystone. And it's actually called, this article in the literature, the Italian experience. So they screened 42,000 athletes over about a 10-year period, and they had, having a centralized healthcare system in Italy, they had all this information in a closed system, so they could get all the data, which is a real advantage compared to here in the United States. But they looked at the sudden cardiac death rates in athletes before and after implementing an ECG screening program as part of the pre-participation exam. So it's an observational study. There was a period of time where they didn't have the ECG. They passed a law. They made the ECG part of the pre-participation exam, and then they had a period of time afterwards. And what we see is there's a dramatic decline in sudden cardiac death from 3.6 per 100,000 per year to 0.4, which is about a 90% decrease. Very dramatic. And what we want to take out of this study is, okay, well, that's pretty compelling evidence. What's the problem here? The first thing is that 9% had a positive ECG, and 2% were disqualified, 2% of the athletes. So the positive ECG rate is similar. It's on the upper end of what's reported in the United States, which is 5 to 10% are going to have a positive ECG if you screen athletes. But the 2% disqualification rate is really rather high. That's it's 1 in 50 athletes was disqualified from participating. And this in Italy is a lifetime disqualification. So they can't participate. And again, because the way they have things set up is a little more centralized, they can't participate in high school or scholastic athletics, but also in a lot of recreational athletics. So if you have 100 players on a football team, 2 of them are going to be disqualified on average by using the screening thing. And I'm not sure that gels with what we understand about cardiac conditions and sudden cardiac death risk in the United States anyway. So that's really the first issue. Another thing is that the sudden cardiac death rate of 3.6% or 3.6 per 100,000 before they had ECG is much, much higher than it reported in any other population, any other study. So it's unclear why it's so high in this particular population. And then the post rate of 0.4 per 100,000 is really in the same range as what the United States is without ECG screening. So many have said by implementing ECG in Italy, they've actually improved their sudden cardiac death rate to be equal to what it is in America. The question is, why was it so high to start with? It's interesting. They also looked at non-athletes during the same period in Italy, and the sudden cardiac death rate was about 0.8 per 100,000, which again, even at the look at the same time frame, that was only 25% of what the rate was in the athletes. So again, why did the athletes have such high sudden cardiac death? And there may be many reasons why. One of them just simply because athletics is a very strenuous activity, and that may have led to exacerbation of underlying conditions. Another issue with this study and trying to extrapolate it to the United States is that the 2 leading causes of sudden cardiac death in this study, ARVD and atherosclerosis, are not leading causes in the United States. It's hypertrophic cardiomyopathy. And in the United States, interestingly enough, the rate, at least in the 15 to 24-year-old group, of atherosclerosis causing sudden cardiac death is so low that it can't even be estimated. It's estimated that it's got to be somewhere in the neighborhood of 1 in a million. Now, this population in Italy was 15 to 35-year-olds, which suggests that, okay, when you get into your 30s, you certainly are at risk for your typical cardiac conditions we see as we age. So that may have confounded some of their numbers in here and may have led to some of these, why the rate was so high to start with, why the disqualification rate was so high, and so on. And ARVD in America only represents about 4% of sudden cardiac death, whereas here it was 1 in 5 cases. And there's some argument that perhaps this is a genetically linked problem. Again, hypertrophic cardiomyopathy accounts for 1/3 of all sudden cardiac deaths in athletes in America. It's only about 2% in this particular study. So clearly there's probably some population difference. Perhaps in Italy they don't have as many athletes with African heritage, for example, which appears to be a genetic issue here in the United States, since the majority, 2/3 of the cases of HCM in the United States are in African American males. So again, just another difference. And then a final point on this is that atherosclerosis and coronary artery anomalies are not detectable typically by ECG, so it had to be some other part of the screening plan that actually detected these people. It wasn't adding ECG to the pre-participation exam that detected this 30% of the cases. So using ECG isn't going to lower, alone by itself is not going to, it wouldn't be expected to, I should say, wouldn't be expected to decrease these particular risks. All right, another study that is actually a little less talked about, but I think is kind of interesting, was published in Medicine, Science, and Sports and Exercise in 2006, called the Japanese Experience. And in Japan, they followed 37,000 students for 6 years. So the same students over a 6-year period, and they had 2 to 3 ECGs during that period. So this is a longitudinal study as opposed to looking at 2 existing groups at different periods of time, like the Italian study. Another thing that's interesting about this, they screened all students, not just athletes. And what they found is 2.7% of these students had a positive ECG, at least one during the 6-year period. They found also that there were 3 sudden cardiac death cases over this period, which is, if you do the math, it works out to 1.3 per 100,000 athletes per year, or per students per year, I'm sorry. And this was done in the 90s. So some issues with this, comparing to the Italians, and then again trying to extrapolate to the United States. This 2.7 positive ECG rate is one of the lowest reported in the literature. Again, in the United States, I've never seen anything reported below 5%, and most of the time it's closer to 8 or 10%. The Italian study was 9%. So there's some question as to how the ECG rate was this low, and it may just, again, if in the population that the rate of cardiac abnormalities is that low, then perhaps we'd have a lower ECG rate. But having said that, we also see that the sudden cardiac death rate was 2 to 3 times higher than in the United States, which would suggest that actually you should have had a lot more positive ECGs. And in fact, what we may be running into, especially considering that 2 out of 3 cases were not detected in screening, and both of them had what were termed normal ECGs at 2 different time points in both athletes. It was 7th and 10th grade. Both had normal, what was considered normal ECG, and then went on to have a sudden cardiac death event at some point in the next 5 to 6 years. This perhaps suggests that their screening criteria, what they said was a positive ECG, may have been too stringent, and in fact, what they weren't identifying enough athletes. And again, there's always that trade-off. You know, you can identify a whole bunch, but you know most of them are false positives, or you can screen out a whole bunch, but then you know some of them are going to be false negatives. So that's the balance that has to be played, and I think this study does a good job of demonstrating, especially when you contrast it with the Italian study. So the fourth challenge is there are guidelines out there for pre-participation exam, but they're somewhat inconsistent, especially if you consider worldwide, and in some cases actually conflict with each other. And something to keep in mind is different populations may require different screening strategies. And what I mean by that is, again, some people, we know African American males are at higher risk for hypertrophic cardiomyopathy. They may require a different screening program than someone who, a Caucasian female who's a swimmer or a diver. is a different risk profile and may require a different screening workup than the first case. I just do want to note quickly down on this graphic, and I believe you're all going to get a copy of this presentation, or I can certainly send it to you. This is the pre-participation physical evaluation manual. It's published by the American Academy of Pediatrics, but American Academy of Family Physicians, American College of Sports Medicine, American Medical Society for Sports Medicine, American Orthopedic Society for Sports Medicine, all participated in the authorship of this set of guidelines, and involves much more than just cardiac issues. It's the whole gamut of pre-participation processes, and it's been endorsed by the American Heart Association and by NATA, so it's an excellent reference if you're thinking about reviewing your pre-participation processes. Okay, so let's get down to the nitty-gritty and talk about feasibility and costs a little bit, because there are many arguments as to whether can you actually do this in a practical sense, and are we going to be able to afford it. And it turns out that if you look at these numbers, this is probably feasible. That the costs and the time are not really what the limiting issue is here on a per athlete basis. One of the limiting things is you need experienced physicians and probably cardiologists to interpret the ECGs, because again, these are not your normal, or well, they are normal, but children are different than adults. You can't get a general family practitioner, for example, may not have the experience of looking at, especially after adaptation to athletic events, looking at a cardiac ECG from a child who's been participating in endurance athletics, for example. Their ECG is going to look different, but it's still within normal confines. So as just a purely can we do it physically issue, it doesn't seem to be a stopping point there. But another aspect of feasibility is this whole what do we do with the positive ECG issue? And a few people I've talked to that have implemented programs, test programs to see if this is feasible, very quickly run into this, and they said it's a real issue, and they absolutely encouraged me to talk about it. Because keeping in mind that 94 to 99% of the people with a positive ECG are probably completely healthy and have nothing wrong with them. So how do you notify parents and athletes without scaring them to death? And then there are a whole bunch of other issues, such as do we hold them from sports or exclude them from sports till they get more testing? Do we allow them to participate, but they have to get more testing within a certain period? These become real issues that you sort of have to have planned out ahead of time. And one of the biggest ones is what are you going to recommend once they have a positive ECG for follow-up testing? Are they going to be referred to somewhere? Is part of that fall under the school's responsibility as the PPE provider? What if the patient refuses either to get the original ECG or they have a positive ECG and you say you need further testing and they just flat out refuse to do it, which from what I can tell in the limited reports there are is about 1 in 20 people are going to do that. You sort of have to have a plan in place to do that, and that's what I think becomes the bigger feasibility issue is how are you going to handle all the positive ECGs that you get. Another issue is costs, and this is the paper Mark and I worked on, again, the June issue of Journal Athletic Training. And you can go through, and we have a worksheet in there that you can put in what numbers you want and see how it changes all of these things. But essentially what we found was that the total cost for screening the high school population in America, and this would be only screening the freshmen, so not all 4 years of high school, just screening incoming freshmen, and they don't get a screening test after that. If they're clean or pass when they're a freshman, then they're good to go for the rest of the year with respect to, or career with respect to ECG. But our estimates, it would be about $126 million a year nationwide. It would be about $100,000 to find one additional cardiovascular or cardiac abnormality, and it would be about $2,700 per year of life saved. So seeing as I was critical of other papers, I probably should be a little critical of my own and talk about what people have, reviewers, when we sent the paper in for publication, and then since then feedback I've received. Again, our prevalence rate is lower than what's the general population, and our reasoning was that people with severe cardiac conditions wouldn't be in athletics, so they wouldn't fall under this definition. The sensitivity and specificity rates I've already touched on, that these were in 2008 pretty much the optimal numbers, and it turns out that very recent, like this year articles, these numbers are a little bit low. if you increase those numbers to sort of the best case scenario, then it probably, well, it'll decrease the cost estimate. And these, what does the ECG cost to do originally, and then what's the follow-up testing cost is highly debated. I've seen the ECG cost as low as free. I don't think that's really realistic. Nothing is free, but $2 to $3 is probably realistic. Up to the AHA thinks it costs $50. I'm not sure where they're getting that number, but there's obviously a lot of discrepancy, as there is with the follow-up testing, ranging anywhere from $100 up to $500 or even $1,000. And this $2,700 per year life saved is within the $50,000 standard. In epidemiology, they say if it's $50,000 per year life saved or less, then in general it's a good plan to implement. This is well under that, but again, highly debated. Some people have reported as low as $300 per year. The AHA actually reports it's $90,000 to $100,000, which would be well over the $50,000 criteria. I think it's worth pointing out neither our study or the lower end studies include the treatment costs. Some of these treatments involve cardiac surgery and even transplants, cardiac transplant, which of course runs into hundreds of thousands of dollars. If you include those in your model, which AHA did, then the costs go up significantly. But this is far from a resolved issue, and like I said, you could go into the article and use a worksheet to put in your own costs. But it's a highly debated issue. My opinion is that this is not the limiting factor. The limiting factor is the inaccuracy of the test, and what are you going to do with all the false positive tests? If you didn't have to address that, the cost problem would take care of itself. Just some other issues very briefly. Legal considerations. People ask about this a lot. It sort of varies state to state. Is the interpreting physician, who oftentimes is doing this as a volunteer service, what's their liability toward either detecting or not detecting someone with the condition? And that's a good question, and it certainly should be answered before you implement a program. Are you excluding people from school athletics? Well, probably, but are you excluding them from all athletics? So recreational and competitive sports outside the scholastic arena, if they're excluded from school, why wouldn't they be excluded from these other conditions? But the problem there is, of course, you run into privacy issues, and all the laws associated with that is how do you go to your local club sport and say this person has a cardiac condition and shouldn't be participating? Really, that's probably private health information and shouldn't be released. But it's something to consider, is that kids these days are playing in many different sports and leagues, and if you're excluding them from one, then the logic would be you exclude them from them all, but practically speaking, how do you do that? So our challenge is that you can get an ECG on everybody, but what do you do with it when you get a positive test? And the cost issue is a real one. No one wants to put a price on a life, but in the end, someone is going to have to pay for all the follow-up costs, because if you detect someone who has a cardiac abnormality or a potential abnormality and you don't do all the testing follow-up and you don't do treatment on the condition when you find it, then there's no point in doing the screening, because the person may potentially have a cardiac event and it wasn't prevented. So the cost issue is a real one, but I really think the limiting factor right now is the inaccuracy of the test being able to detect the condition. So I'm going to summarize the challenges quickly and just talk about, okay, if you're going to do this in your arena, how are you going to do it? Here's what the 5 challenges were. I'm not going to sit and read them to you, but we went through each one of these, and there was some rationale behind these challenges. And I think more importantly is, okay, how are we going to address these challenges? So I think keeping in mind when you set out to do, if you're going to implement an ECG screening program, is that it identifies cardiac problems, not risk of sudden cardiac death. You're finding the haystacks, not the needles. And keeping that perspective in mind, I think, will help you to prepare to implement the program, but also help you when you're actually interpreting ECG and taking action on that. Another thing may be to consider identifying higher risk athletes using the typical history and physical, and then certainly combining results of multiple tests. So if I do one test and it's positive, you may have the condition. If I do 5 tests and they're all positive, it's very likely you have the condition. And that's where the follow-up testing becomes very important. Doing an echo or a stress test or whatever a cardiologist might think is important is that if you're going to rule out them having a cardiac condition, any one of those tests negative, they probably don't have it. But all 5 of them positive gives you much stronger evidence that they do. So using the ECG alone is not necessarily a good idea. And again, that's what the third point ties into the first 2. Using the AHA guidelines should be a minimum standard. Again, I think, and this is one of my soapbox issues, that I mean we can't get people to do the standard guidelines right now, and now we're going to make them more complicated. I don't think that's going to be successful from a practical standpoint. I think the first order of business is getting everyone in line with the AHA guidelines. And then you can always augment it with ECG, and certainly some point in the future that'll probably become a standard. But right now, if we have athletes participating who have never had a legitimate physical exam, that's a real problem. And then create a complete response plan, including what the approximate costs are and who's going to be paying who would be expected to pay the cost before you start doing the testing and get buy-in from all the stakeholders. And we're going to talk about stakeholders in a minute. So just concluding the talk, and then like I said, I have 3 or 4 slides about things for you to consider if you're going to do this. ECG is an adjunct to a properly conducted physical exam or pre-participation exam. And again, the AHA thing is really what should be the minimum standard, and then we can add on to it. But ECG by itself is not going to be effective. It has to be interpreted in light of the other findings. And then know what to expect and plan accordingly. And the main thing you're going to expect is a lot of false positives. You're going to get positive tests in healthy people. Maybe you should consider or may consider alternate testing protocols. Again, the risk stratification issue. And then just have lined out what is it you're going to do for positive tests so that it's equitable across all your athletes. So is it right for me in my setting and population? Again, I'm just going to go through these things to think about. And when you get this presentation, if your area is thinking about doing this, you can perhaps use this as a mode of starting the conversation. So who are you screening? All the athletes? Are you going to do a risk stratification? Are you going to do high-risk sports only, football and basketball, which obviously is going to run into some, I don't want to say political, like national political, but there's obviously issues with if you're going to screen football and nothing else. Are you going to do all students? Why are we just screening athletes? This is a public health problem. Can we implement it in a school-wide program rather than just an athlete program? Because again, a lot of the kids with conditions probably aren't participating in athletics because they have the condition, but they don't know they have it. You may save lives that way. Are you going to require it, or is it going to be optional? Are you going to be charging a fee for it? Anytime you start to charge a fee, no matter how small it is, there are disparities that come into play that need to be considered. So, first thing, who are you screening exactly? How are you screening? I think several programs, they sort of do everybody all at one time, like the typical mass physical screening scenario. But I think here in the Houston area, someone's done a very innovative program where they do it incrementally. So they'll do, the varsity football team one week, they'll do JV the next week, they'll do, sophomores or the freshmen after that, and so on. And so they'll do teams or groups of people, and it takes them a whole year to get all the testing done. But that way, it spreads it out over the whole year, and there's not a huge personnel and time and expense demand all at one time. It's spread out over a year. Are you going to do it every year? That's probably unnecessary, but it certainly is worth considering that some of these things are detectable as early as late childhood, and it may be better to screen people in junior high and then again on entry to high school. Again, a whole host of logistic issues come into play there. The physicians who are interpreting the ECGs, are they volunteering? Have they made a time commitment? And more importantly, do they have training and experience in reading ECGs of children and adolescents who are physically active and have been physically active? Because those ECGs don't look like everybody else's. And I will say that the Italian group, in conjunction with AHA and the European Heart Journal, just put out an excellent article on ECG interpretation for athletes and young athletes in particular that really should be the standard reference going forward. Plan your response to a positive test. The vast majority have no cardiac problems. Create scripts for every step of the test. What are you going to tell someone when the parent and the child, when they have a positive ECG? That, okay, the ECG is inconclusive perhaps. It indicates something, but really we need more testing to clarify what it's telling us, because most of the time it's nothing. Just to put their mind at ease, you're walking a line between scaring them and them being complacent about it. The follow-up testing needs to be done, but you don't want to alarm people because, again, most of them are perfectly healthy and don't have a condition. What are you going to recommend for follow-up testing? That should be standard, and costs are going to become a real issue at some point, and especially, again, given different socioeconomic status and insurance access to care in general in rural areas, for example. I mean, how are you going to implement that follow-up plan. And then who's deciding about exclusion from participation? School districts and physicians can exclude people from participation. It doesn't matter how many second opinions you get and whatever, and that's been upheld in the courts for the most part, but it really needs to be very clear going into it is when we say you're excluded, then that's the final word. You can't go get a second opinion and come back and et cetera, et cetera. And I think I just want to end by saying that involve the stakeholders. That the school district's going to want to know you're doing this. There's risk managers and so on at school districts. Certainly the legal people, the people doing medical records or any kind of records keeping, but also parent groups, coaching staff, perhaps your insurance agents and adjusters. They're all going to want to know what you're doing this for also, and giving them some good information and making clear what the purpose of it is. I know that one of my colleagues was telling me they had a program they had implemented, and one of the parents refused to participate because they thought the doctor was just doing it to enrich themselves. You know, they're a cardiac surgeon. They're making plenty of money. They're doing it because they're trying to prevent this from happening on the field. And then lastly, legislators, that if you're going to go and argue before legislators, have your facts, because I can assure you that they do. And it's going to be an uphill battle because, again, public health money is very short, and there are many, many more conditions that lead to death in this age group. But this is a very important to our particular profession, but also just athletes in general. So legislators may be some people to get involved at all levels, local, state, national, and so on. I think in the future we're going to have more legislation related to, including ECG and other types of testing in athletics. So I want to thank you for participating in this inaugural webinar, and I hope you found it informative and useful. And I'm going to turn it back to Lindsay.
For more information on the topic today, please refer to the following references. The 2010 June issue of the Journal of Athletic Training to find Dan's article on pre-participation physical exams, the 2007 American Heart Association update for pre-participation screening, the 36th Bethesda Conference. This national conference provides the standard for athletes with cardiovascular conditions, and Dan has also provided his email address for other questions. Finally, please visit the NATA Knowledge Center, which can be found on the NATA website under Quick Links. You will find upcoming webinars as well as other NATA educational offerings. If you have questions about NATA educational offerings, please email us at knowledgeinitiatives@nata.org. And now, let's cover some questions. Dan, can you state the first question?
The first question they asked, with the study that had a prevalence of 0.68%, which was higher, was there any difference in the ECG or methods of testing to get increased accuracy? And the answer is they didn't report that, but yeah, there probably was. That they were probably using the more recent, and like I said, the last year or two criteria for interpreting an ECG, which is from the preliminary reports in the literature has made a huge difference and made that interpreting the ECG in adolescent athletes much, much more accurate. So they were probably using those newer criteria for what can be considered a positive ECG and what's considered just normal variation, and that would increase that the accuracy of the test. Is there a difference between physicians and screening exams? For example, do cardiologists have greater accuracy in reading ECG or performing auscultation during physical exam? And that's sort of a whole other topic in and of itself. I mean, the short answer is yes, because they've done it 10,000 more times than other physicians. That's not to say that other physicians can't do it. It's just what experience do they have? And again, when you get into a population of children who have been physically active in most cases for much of their life, their heart is adapting and growing at the same time. And we know that children have more wider normal variation in their ECG reading. And then when you add athletics on top of that, it becomes very difficult or complex to interpret. And certainly cardiologists, particularly those focusing on pediatric practice, would probably be the best, but that's not always possible. And certainly most cardiologists who are aware of this would be highly qualified, and then other physicians who have the experience. So yeah, the short answer again is yes. With a qualification, that doesn't mean that they're the only ones who can do it. Do you recommend a 12-lead ECG or 4-lead ECG? I'm not recommending either one of those because I'm not sure that that's my place. I mean, one versus the other. But if you're going to do ECG, I think what the Italians did was a 12-lead. And I think if you're going to do an ECG, 12 leads probably the way to go. It gives you much, much more information than the simple 4-lead ECG, and cardiologists can get a cleaner read off of it. And it really doesn't add a whole lot, from what I understand, to people that have implemented these programs. The 12-lead ECG doesn't add a lot in time and effort and costs and so on. So it's as easy to do and gives you a lot more information. It's probably the way to go. Where can we obtain the pre-participation exam book? That you can get it online. Again, it's published by the American Academy of Pediatrics. I think that's the right name. Let me look real fast. But if you just look up pre-participation exam, or physical evaluation, I'm sorry, and 4th edition in Google or something, it'll pop up. I'm pretty sure it's available on Amazon or any of those, but you can get it directly from the American Academy of Pediatrics website also. And it's not very, I want to say it's $25 or $30. Are there high schools in the U.S. or Texas that are currently implement ECG screenings? I know for a fact that there's Cy-Fair ISD here in the state of Texas, here in Houston actually. Well, technically it's not Houston, but Greater Houston area, is doing that as a routine part of their screening program. They do it for all incoming freshmen. Again, it takes them a year. They're the school that does it in an incremental fashion rather than all at one time. But they are doing it, and they're going to continue doing it, and they're constantly improving their program, and they're a great source of information for me. And I know there are other high schools in the United States. I don't know them off the top of my head. And I know that Mesquite ISD for a year or two had an echocardiograph screening program that they used to some success. Does a Division I athletic population change your outlook on the usefulness of the ECG and PPs? And again, I mean, I think my outlook is, I'm not sure what you mean by my outlook. I mean, my outlook is that ECG can be a useful test if you know what to expect. If you just start using it sort of naively, you're going to get all these false positives, and then what do you do with them? I think hopefully that's the message that came through. I'm not saying to do an ECG. I'm not saying not to do it. But if you are, know what to expect. And Division I athletic population, again, this is college is a little bit different. They have a lot fewer athletes. Just the nature of the intensity of college athletics versus high school, and the fact that you have to be invited, so to speak, to get into a college athletic setting. You've probably screened out a bunch of people who have cardiac conditions who just simply are not able to perform at that level. So it changes the whole scenario. I think that there are some of the bigger colleges, and certainly I believe most of the professional sports have added ECG and echocardiograph to their pre-participation, and in some cases annual physical exams. And I don't think that's necessarily a bad idea. As the people start to get older, and I'm not an athlete by any stretch of the imagination. When I have my annual physical exam, they give me an ECG. So it starts to have more utility, because as people age, they're more and more likely to have these diseases. The prevalence goes up. You know, again, I'm not. My students will tell you I can talk until the cows come home, but the short answer is I think in college and pro sports you're looking at a different scenario, and that using ECG there, because you're going to be able to do a lot more of the follow-up testing, and you have a lot more control in-house, so to speak. It's just a different scenario.
And I just wanted to tell Dan, thank you for covering those questions, and we appreciate this excellent presentation today. I also want to thank everyone for joining us for the very first NATA webinar. This concludes our session, and I hope everyone has a great day.